Your patient becomes visibly upset when told she can be discharged. How would you deal with this situation?
If a patient becomes visibly upset upon hearing about their discharge, particularly after a significant surgical procedure like a total knee replacement, my immediate response would be to recognize and validate their emotional reaction. Discharge can evoke a range of feelings: relief, certainly, but also anxiety, fear, and a sense of loss of security, especially after a period of intensive hospital care. Therefore, I would first ensure we are in a private and comfortable setting, away from the busier ward environment, to allow the patient to express their feelings openly without feeling self-conscious. I would then actively listen to their concerns, asking open-ended questions like, "I can see you're feeling upset about your discharge. Can you tell me what's making you feel this way?" Or, "What are your biggest worries about going home?" It's crucial at this stage to truly hear and understand their specific anxieties. Perhaps they are worried about managing pain at home, unsure about wound care, anxious about mobility, or simply feel unprepared to leave the security of the hospital environment after their knee replacement surgery. Based on their expressed concerns, I would then tailor my response to directly address each specific point. If their anxiety stems from pain management, I would reiterate the discharge pain plan in detail, reviewing the prescribed medications, dosages, and administration schedule, ensuring they have a clear written pain management plan and understand how to access pain relief at home, perhaps even providing a demonstration of effective pain management techniques and ensuring they have adequate supplies of medication on discharge. If their concern is wound care, I would thoroughly review wound care instructions, both verbally and in writing, ensuring they, or their caregiver, are confident in performing dressing changes and know the signs and symptoms of infection to watch for and who to contact if concerned. If mobility is a worry, I would recap their current mobility status, review their physiotherapy plan for home, ensure they have any necessary mobility aids like crutches or a walker organized, and connect them with community-based physiotherapy or occupational therapy services if required for ongoing rehabilitation after their knee replacement. Crucially, I would also assess their level of social support at home. If they live alone or have limited support, I would proactively involve our hospital social work team to ensure appropriate support services are in place for a safe and successful discharge, such as home health nursing visits or community support programs for patients recovering from orthopedic surgery. Throughout this conversation, I would consistently offer reassurance and positive reinforcement, emphasizing their progress throughout their hospital stay, highlighting their achievements in recovery post-surgery, and empowering them to feel confident and capable of managing at home with the resources and support we are providing. Ultimately, my goal is to transform their anxiety into confidence by directly addressing their individual concerns, providing comprehensive discharge education and planning, ensuring adequate support networks are in place, and fostering a sense of empowerment as they transition back home after their knee replacement surgery and hospital stay.
What measures will you put in place if a patient is really anxious and wants to be visited by family when there are currently no visitors allowed in the hospital?
If a patient, such as a younger patient undergoing cancer treatment who is feeling intensely isolated and emotionally distressed, were to become really anxious and express a strong desire for family visits when hospital visitor restrictions are unfortunately still in place due to ongoing public health concerns regarding a new variant of COVID-19, my priority would be to acknowledge and deeply validate their anxiety and explore absolutely every possible and safe avenue to facilitate meaningful connection with their family, whilst rigorously adhering to the necessary hospital policy and infection control guidelines. Firstly, and most importantly, I would prioritize empathetic and compassionate listening, deeply validating the patient's understandable anxiety and profound distress at being separated from their family, especially during a stressful and emotionally challenging time like cancer treatment, clearly and sensitively explaining the rationale behind the very difficult visitor restrictions, emphasizing patient safety, protection of all vulnerable patients on the oncology ward, and wider public health concerns as the absolute drivers for maintaining the policy. I would then immediately and proactively explore every single alternative method of facilitating connection with their family that is safe, practical, and emotionally meaningful for the patient and their loved ones, going above and beyond standard options. This would certainly include proactively facilitating and maximizing frequent and extended virtual visits using the ward's dedicated tablet devices or ensuring family have support to set up reliable video calls on their personal devices, providing technical assistance as needed and proactively scheduling these virtual visits at times convenient for both the patient and their family, making these calls a regular and anticipated part of their day. Beyond standard virtual visits, would also actively investigate and advocate for any possibility of more creative and compassionate solutions to enhance family connection within the constraints of the visitor policy. This might include exploring the potential for window visits if the patient's room allows, carefully coordinated outdoor socially distanced visits in a designated hospital garden area if the patient is well enough to mobilize, or even facilitating pre-arranged phone calls with family during specific times when the patient knows to expect the call and can have dedicated quiet time to connect. I would also strongly advocate for consideration of a compassionate, exceptions-based in-person visit with the ward manager and infection control team, meticulously exploring the possibility, particularly if the patient's emotional distress is overwhelming, they are facing a significant emotional or psychological challenge due to isolation, or if their clinical condition is deteriorating and family presence is deemed crucial for emotional well-being, even if a full in-person visit is not possible. If any form of limited in-person visit is exceptionally approved as a compassionate exception, I would ensure meticulous and uncompromising adherence to the strictest infection control measures, working closely with the family to ensure they fully understand and commit to pre-screening for symptoms, strictly limiting the visit to a very short duration and to only one essential family member, ensuring mandatory and correct use of enhanced PPE including N95 masks and gowns, rigorous hand hygiene, and designating a completely safe and isolated visiting area, such as a negative pressure isolation room if available, or a carefully designated area away from all other patients, to absolutely minimize any potential infection risk to the patient and to all other vulnerable individuals in the hospital. Crucially, alongside exploring all these avenues for family connection, I would also significantly enhance my own nursing presence, emotional support and therapeutic communication with the patient to actively combat their feelings of isolation and profound anxiety during this challenging visitor restriction period. This would mean intentionally dedicating even more time to spend with the patient, offering frequent and genuine reassurance and empathetic listening, proactively engaging in meaningful conversations beyond just routine care tasks, actively assessing their emotional state and mental well-being, and providing a range of diversional activities tailored to their interests, such as reading aloud, playing calming music, facilitating access to online mindfulness or relaxation resources, or simply offering quiet companionship and a consistent, reassuring presence to alleviate their distress and feelings of profound loneliness in the enforced absence of physical family visits. I would also ensure the patient is comprehensively assessed for and has immediate access to other essential hospital support services, such as referral to the oncology social work team for specialized psychosocial support, consultation with the hospital chaplaincy for spiritual comfort if desired, or referral to the psychology team for further assessment and management of their anxiety and distress, ensuring a truly holistic and patient-centered approach to managing this very difficult situation. In essence, my comprehensive and compassionate approach would be to meticulously balance the patient's critical emotional and social needs with the absolute imperative of stringent infection prevention and adherence to hospital policy during visitor restrictions, tirelessly exploring and advocating for every safe and policy-compliant option to maximize family connection and alleviate isolation, whilst concurrently maximizing my own enhanced supportive nursing presence and diligently utilizing all available hospital resources and multidisciplinary team expertise to effectively manage the patient's very understandable anxiety and profound emotional distress in this exceptionally challenging and isolating situation.
Tell us about a time when you were unable to do what you said you would do.
There have been inevitable instances in my nursing practice where, despite my best intentions, I was unable to fulfill a commitment exactly as initially planned. One example occurred during a particularly busy shift on the surgical admissions unit. I had promised a newly admitted patient, Mrs. Davies, who was quite anxious and awaiting urgent appendectomy surgery, that I would personally ensure her family was updated immediately after her surgery and that I would call them within an hour post-operatively to give them an update and reassure them. However, shortly after Mrs. Davies went to the theater, we experienced a sudden influx of emergency admissions, including a major trauma patient requiring immediate resuscitation and a patient with a suspected perforated bowel needing urgent surgical intervention. Managing these critical emergencies, coordinating care, and ensuring patient safety became the absolute priority, demanding my full and immediate attention, as well as the attention of the entire nursing team. In the midst of managing these critical situations, and with the shift becoming increasingly demanding, I unfortunately realized that more than an hour had passed since Mrs. Davies' surgery, and I had not yet been able to contact her family as I had promised. As soon as the immediate emergencies were stabilized and patient care was safely handed over, I immediately recognized my oversight and the unmet commitment to Mrs. Davies' family. My first action was to promptly contact Mrs. Davies' family myself, sincerely apologizing for the delay in communication and explaining honestly and transparently the unforeseen emergency circumstances on the unit that had understandably diverted my immediate attention. I provided them with a comprehensive update on Mrs. Davies' surgery and her immediate post-operative condition, reassuring them that she had come through the procedure well and was stable in recovery. I also made sure to personally visit Mrs. Davies in the recovery area as soon as possible after contacting her family, explaining the situation to her directly, and again sincerely apologizing for not being able to update her family as promptly as I had initially intended. I ensured she was comfortable, reassured her surgery had been successful, and reiterated that her family had now been updated and were relieved. To prevent similar situations in the future, I reflected on this incident and recognized the importance of robust time management and contingency planning, particularly in a fast-paced and unpredictable environment like surgical admissions. Since then, I have implemented strategies such as setting timely reminders and prioritizing communication tasks even during busy periods, and also, importantly, proactively communicating potential delays or changes in plans to patients and families as early as possible when unforeseen circumstances arise, rather than waiting until after a commitment is missed. This experience underscored the importance of honesty, accountability, and proactive communication in managing unavoidable deviations from planned commitments, and the critical need for robust time management strategies, particularly in demanding and unpredictable surgical nursing settings, while always prioritizing patient and family well-being and clear communication.
How do you think the role of the nurse differs between India and England?
Based on my understanding and research, and considering the experiences of colleagues who have practiced in both India and England, there are several key differences in the nursing role between these two countries, particularly in areas such as drug names and administration, nurses' paperwork and documentation, working hours and staffing ratios, and the approach to reflective practice. Regarding drug names, a significant difference lies in the common use of generic drug names in India versus the more prevalent use of branded drug names in England. This requires nurses transitioning between these systems to develop familiarity with both generic and brand names to ensure safe medication administration and prevent errors. Additionally, the availability and range of certain medications and formulations may differ, necessitating adaptation to local formularies and prescribing practices in each country. In terms of nurses' paperwork and documentation, while both countries emphasize thorough and accurate record-keeping, there can be variations in the specific documentation systems and formats used. England predominantly utilizes electronic health record systems, whereas paper-based documentation may still be more prevalent in some settings in India. Furthermore, the specific details and level of granularity required in nursing documentation may differ, reflecting variations in legal and professional standards and healthcare system structures between the two countries. Concerning working hours and staffing ratios, while both countries face pressures on nursing resources, there are often notable differences in typical nurse-to-patient ratios and average working hours. Anecdotally, staffing ratios may be more challenging in some settings in India, potentially leading to heavier workloads and different time management demands compared to the UK context, where there are more regulated staffing guidelines, although pressures still exist. Finally, regarding using reflection to learn from practice, while reflection is increasingly recognized as a valuable tool for professional development in nursing globally, the formal emphasis and integration of reflective practice into routine nursing workflows and continuing professional development may vary. Reflective practice is highly emphasized and structurally integrated into nursing professional development and registration requirements in England, whereas the formal implementation and cultural integration of reflective practice may be at different stages of development within nursing in India. Despite these differences, the core values of nursing, patient safety, compassionate care, and professional commitment, remain consistent across both India and England. Nurses in both countries are dedicated to providing high-quality care within their respective healthcare systems, and the key for nurses transitioning between these systems is adaptability, a willingness to learn and embrace new protocols and practices, and a commitment to providing culturally competent and patient-centered care within the specific context of their practice setting.
Do you keep up to date about changes in healthcare/medicine?
Absolutely. Proactively keeping up to date with changes in healthcare and medicine is a fundamental aspect of my professional commitment as a surgical nurse. Given the constantly evolving nature of healthcare, particularly in surgical specialties with rapid advancements in techniques and technologies, continuous learning is not just beneficial but essential for providing the best possible patient care. I employ several strategies to stay current. Firstly, I regularly engage with peer-reviewed nursing and medical journals, specifically those focused on surgical nursing and my areas of specialization, such as the Journal of Perioperative Nursing and the British Journal of Surgery. I make it a habit to review table of contents and relevant articles to stay informed about new research findings, evolving best practices, and advancements in surgical procedures and post-operative care protocols. Secondly, I actively participate in continuing professional development, CPD, activities, both within and outside of the hospital. This includes attending hospital-sponsored in-service training sessions on new surgical techniques or updated infection control guidelines, participating in online webinars and e-learning modules on surgical nursing topics, and attending relevant surgical nursing conferences and workshops when possible, such as those organized by the Royal College of Nursing or specialist surgical nursing societies. I meticulously maintain my CPD portfolio, ensuring I meet all revalidation requirements and proactively seeking out learning opportunities to enhance my knowledge and skills. Furthermore, I actively engage with professional online resources and platforms relevant to surgical nursing, such as reputable websites for surgical nursing organizations, evidence-based practice databases like Cochrane Library and NICE Guidelines, and professional nursing forums and discussion groups where I can engage with colleagues and learn about emerging trends and best practices. I also make it a practice to discuss new developments and research findings with colleagues and senior surgical staff during ward-based meetings or informal learning opportunities, fostering a culture of continuous learning within the team and ensuring we are collectively informed about the latest advancements impacting our practice. Finally, I am always receptive to feedback and actively seek opportunities to reflect on my practice and identify areas for improvement, viewing every clinical experience as a learning opportunity in using reflective practice techniques, such as structured reflection using Gibbs' reflective cycle, to analyze my performance, identify knowledge gaps, and proactively seek out information to address them. This proactive and multifaceted approach to continuous learning ensures I remain up to date with changes in healthcare and medicine, allowing me to consistently provide evidence-based and high-quality surgical nursing care.
Give a recent example of how you have tried to improve your performance.
A recent example of my proactive approach to performance improvement centers around enhancing my skills in managing postoperative delirium in elderly surgical patients, a common and challenging issue on the surgical ward for older adults where I previously worked. Recognizing that delirium significantly impacts patient outcomes, increases length of stay, and causes distress for both patients and families, I identified this as an area where I could enhance my practice to improve patient care. Initially, I undertook a period of self-directed learning, reviewing the hospital's clinical guidelines on delirium prevention and management, researching current best practices and evidence-based interventions in reputable nursing journals like the Age and Aging Journal and online resources such as the National Institute for Health and Care Excellence, NICE, Guidelines on Delirium. I focus specifically on non-pharmacological strategies for delirium prevention and management, such as cognitive stimulation, reorientation techniques, sleep hygiene promotion, and early mobilization, recognizing the importance of these approaches in minimizing medication use, particularly in elderly patients. Following this self-education phase, I actively sought opportunities to put my new knowledge into practice on the ward. I focused on proactively implementing non-pharmacological delirium prevention strategies for my elderly postoperative patients, such as initiating regular reality orientation, engaging patients in cognitive activities during bedside care, and advocating for early and consistent mobilization with physiotherapy colleagues. I also consciously focused on improving my delirium assessment skills, utilizing validated assessment tools like the Confusion Assessment Method, CAM, more systematically and diligently to identify early subtle signs of delirium in my patients. Furthermore, I actively sought feedback from senior nurses and the geriatric medicine consultant on the ward regarding my approach to delirium management, asking for specific guidance on how I could further refine my assessment and intervention skills and incorporating their expert advice into my daily practice. I also shared my learning and newly acquired skills with my nursing colleagues during ward handovers and informal discussions, aiming to disseminate best practices within the team and encourage a more proactive and consistent approach to delirium prevention and management across the ward. Finally, to formally evaluate the impact of my focused efforts, I began informally tracking relevant patient outcomes related to delirium in my patient cohort, noting instances of delirium onset, duration, and the effectiveness of implemented non-pharmacological interventions. While this was not a formal audit, it allowed me to reflect on my practice and identify areas for further refinement and ongoing learning. This proactive approach to self-education, practical application, seeking feedback, sharing knowledge, and informally monitoring outcomes demonstrates my commitment to continuous performance improvement and enhancing patient care in a complex area like postoperative delirium management in the surgical setting.
You are on the ward and find a patient unresponsive. What would you do?
Finding a patient unresponsive on the ward immediately triggers a critical emergency response, prioritizing rapid assessment, summoning help, and initiating basic life support according to established protocols. My immediate first action upon discovering an unresponsive patient, for example, Mr. Jones in bed 5, would be to immediately and loudly call for help, activating the ward emergency buzzer or shouting for colleagues to alert the wider team to the emergency situation unfolding. Simultaneously, while calling for help, I would immediately assess the patient's airway, breathing, and circulation, ABC. This rapid primary survey involves checking for responsiveness by attempting to rouse the patient verbally and tactily, opening the airway using a head tilt chin lift maneuver, unless contraindicated by suspected spinal injury, checking for breathing by looking, listening, and feeling for chest movement and breath sounds, and assessing for circulation by checking for a carotid pulse. Based on my ABC assessment, I would then initiate appropriate basic life support interventions immediately. If the patient is not breathing but has a pulse, I would commence rescue breaths, administering breaths at the appropriate rate and depth. If the patient is not breathing and has no pulse, would immediately commence chest compressions, initiating cardiopulmonary resuscitation, CPR, at the correct rate and depth, ensuring effective chest compressions are delivered in line with current resuscitation guidelines. Throughout this initial response, I would continually reassess the patient's ABCs and adapt my interventions accordingly. While initiating basic life support, I would ensure that someone else has already called the hospital emergency response team, often designated as the Code Blue Team or Medical Emergency Team, MET, providing them with the patient's location, ward, and a concise summary of the situation and the patient's condition, stating unresponsive patient in bed 5, surgical ward, no pulse, CPR in progress. Once the emergency response team arrives, would immediately provide a clear and concise handover, detailing the patient's presenting condition, my initial assessment findings, and the interventions already undertaken, including any basic life support measures initiated and vital signs if obtainable. I would then actively assist the emergency response team as directed, providing support during advanced resuscitation efforts, including medication administration, airway management, and further assessments, acting as a runner, documenting events as they unfold, and providing any assistance needed to optimize the resuscitation attempt. Following the immediate resuscitation phase, regardless of the outcome, I would ensure thorough documentation of the entire event, including the time of unresponsiveness, initial assessment findings, interventions performed, the arrival time of the emergency response team, the subsequent management, and the patient's outcome, whether successful resuscitation, transfer to a higher level of care such as ICU, or unfortunately, confirmation of death. This documentation is crucial for accurate patient records, for communication within the healthcare team, and for potential review and learning from the event. In essence, my response to finding an unresponsive patient would be immediate, decisive, and protocol-driven, focused on rapid assessment, summoning expert help, initiating life-saving basic life support measures without delay, and providing seamless handover and assistance to the emergency response team to maximize the patient's chances of a positive outcome.
As an overseas nurse, you have experience giving 4 fluids in a previous role. It is your first week in the clinical area in the UK, and you mentioned this to your colleagues. You have been asked to administer 4 meds. Take us through the process of what you will do. New to UK, not in my role to give medication.
Despite having prior experience administering intravenous fluids and medications in my previous nursing role in India, and even though I may have mentioned this experience to colleagues, upon being asked to administer 4 medications in my first week in a UK clinical setting on the vascular surgical ward, my absolute priority would be to strictly adhere to UK hospital protocols and scope of practice for medication administration, recognizing that these may differ significantly from my previous experience, and ensuring patient safety is paramount. Therefore, my first step, before even considering medication administration, would be to immediately and clearly clarify my scope of practice and confirm my competency to administer 4 medications within the UK context with my supervising nurse or the nurse in charge on the ward. I would explicitly state that while I have prior experience with 4 medication administration from my overseas practice, I am very new to the UK healthcare system and need to confirm the local protocols and my authorized scope of practice within this new setting, emphasizing my commitment to safe and compliant practice. Assuming I am confirmed as appropriately registered with the Nursing and Midwifery Council, NMC, in the UK and that my competency to administer 4 medications is verified as within my current scope of practice under supervision in this initial period, my next step would be to thoroughly familiarize myself with the specific UK hospital's medication administration policy and guidelines for intravenous medications. This would involve carefully reviewing the ward's medication administration protocols, specifically focusing on 4 medication administration, including any local guidelines on medication checking procedures, documentation requirements, and compatibility guidelines for intravenous infusions, and ensuring I understand any specific policies related to my role as a newly registered overseas nurse within the UK system. Prior to administering any specific for medication, would then meticulously verify the medication prescription against the patient's medication chart and the original prescriber's orders, ensuring all rights of medication administration are meticulously checked and double-checked, right patient, right drug, using both brand and generic name to cross-reference, being mindful of potential differences from Indian drug names, right dose, right route, for route specifically confirmed, right time, and right documentation requirements according to UK standards. I would pay particular attention to confirming drug dosages and concentrations, recognizing that medication formulations and strengths can vary between countries, and ensuring I am using the correct UK-specific preparations and dosage calculations. Before preparing the for medication, would also confirm compatibility with any existing intravenous infusions the patient is receiving, and double-check the correct diluent and rate of administration for the specific for medication as per UK guidelines and the prescription, consulting the hospital's for drug compatibility resources and pharmacy guidelines if needed to clarify any uncertainties. For the actual administration process, I would gather all necessary equipment, including appropriate-sized syringes and needles for administration according to UK Sharp's safety guidelines, alcohol swabs for aseptic technique, and appropriate for-giving sets and infusion pumps if required for rate-controlled infusion, ensuring all equipment is UK standard and compliant with local safety regulations. Using strict aseptic technique, I would prepare the medication in a clean environment, carefully drawing up the correct dose and double-checking the medication label against the prescription once again. Immediately prior to administration, I would re-identify the patient using at least 2 patient identifiers as per UK hospital policy, confirming patient name and hospital number against the medication chart and patient wristband, and verbally confirming patient allergies before proceeding. I would then explain the medication and its purpose to the patient, addressing any questions or concerns they may have, ensuring they understand what medication they are receiving and why, in line with UK patient consent and information sharing guidelines. Following administration, I would meticulously and promptly document the medication administration in the electronic patient record according to UK nursing documentation standards, including the drug name, dose, route, time, and my signature and NMC registration number as a UK registered nurse, noting any patient response or observations, and ensuring all documentation is fully compliant with UK legal and professional requirements for medication recording. Throughout this entire process, from initial clarification of scope of practice to final documentation, my overriding focus would be on patient safety and meticulous adherence to UK hospital medication administration policies and professional standards, recognizing that my previous experience in India provides a foundation. But adaptation and rigorous compliance with UK-specific protocols are absolutely essential in my first weeks of practice in this new healthcare system. If at any point I felt unsure or encountered any aspect of the UK medication administration process that was unfamiliar or unclear, I would immediately seek guidance and clarification from a senior UK registered nurse or the ward pharmacist, prioritizing patient safety above all else and recognizing the importance of asking questions and seeking support when working within a new and complex healthcare system.
You observed that one of the doctors undertaking ward rounds had not washed his hands and is wearing a watch. What action would you take?
Observing a doctor on ward rounds not washing their hands and wearing a watch, both being breaches of fundamental infection prevention protocols, would require immediate and appropriately assertive yet respectful action, prioritizing patient safety above all else. My initial approach would be to address the situation directly and respectfully with the doctor in a private and discreet manner, focusing on patient safety and established infection control guidelines, using clear and professional communication. As soon as I observed the lapse in hand hygiene and the watch, I would politely and discreetly approach the doctor, perhaps as they moved away from the patient's bedside or in a quiet corner of the ward, to ensure privacy and minimize any potential embarrassment. Using a calm and non-confrontational tone, would clearly and directly communicate my observation and concern, referencing established infection control protocols. For instance, I might say something like, "Excuse me doctor, I noticed you were moving between patients and haven't had a chance to wash your hands just now. And also, I believe ward policy is for all staff to be bare below the elbows during ward rounds for infection control. Perhaps we could just take a moment to use the hand gel before you see the next patient?" Or, "Doctor, just a quick reminder for infection control, ward policy is for hand hygiene between each patient contact, and also no wristwatches during patient interactions. Could we just ensure we're both adhering to these guidelines as we continue ward rounds?" This approach is direct and clear in stating the issue, but also respectful and framed as a gentle reminder of established protocols, focusing on patient safety as the shared priority, and offering a practical solution like using hand gel immediately available at most bedsides. The key is to communicate assertively but professionally, avoiding accusatory language and maintaining a respectful tone while clearly addressing the infection control breach. In most situations, a direct and polite reminder from a nursing colleague is usually sufficient to prompt immediate corrective action from a medical colleague, particularly when framed around shared patient safety goals. However, if, for any reason, the doctor were to dismiss my concern, become defensive, or not take immediate corrective action, i.e., still not perform hand hygiene or remove the watch, then it would be my professional responsibility to escalate the concern to a more senior member of staff according to hospital policy for infection control breaches. This escalation pathway might involve immediately informing the ward's nurse in charge or the ward manager, clearly explaining the situation, the observed breach of infection control protocols, and the doctor's lack of response to my direct and polite intervention. Escalation is a crucial step when direct communication is ineffective in addressing a patient safety risk. The senior nurse or ward manager would then be responsible for addressing the issue further with the doctor, potentially involving senior medical staff or the infection control team if necessary, ensuring appropriate action is taken to rectify the breach and reinforce infection control standards. Documentation of the incident may also be required as per local hospital policy, particularly if escalation is needed. In summary, my action would be to initially address the issue directly and respectfully with clear communication focused on patient safety and adherence to protocol, but to escalate appropriately and promptly if the direct intervention is not effective in ensuring immediate corrective action, ultimately prioritizing patient safety and upholding infection control standards as paramount.
Tell us about the biggest change that you have had to deal with. How did you cope with it?
The biggest professional change I've had to navigate in my nursing career was transitioning from a very busy, high-acuity surgical unit in a large metropolitan hospital in India to a smaller, more specialized surgical center in a rural area in the UK. This transition encompassed a significant shift in not only the healthcare system and practice environment, but also cultural and social adjustments. In my previous role at Apollo Hospital in Chennai, I was accustomed to a fast-paced, resource-intense environment managing a high volume of complex surgical patients, often with limited resources and high patient-to-nurse ratios. The ward was constantly dynamic, demanding rapid decision-making, efficient task management, and adaptability to unpredictable emergency situations. Upon moving to the UK to work at the Royal Cornwall Hospital's NHS Trust, while the core nursing principles remained the same, the practice environment was markedly different. The surgical centre, while providing excellent care, was smaller and served a more geographically dispersed, rural population. Staffing ratios were more structured and supportive, resources were more readily available, and the pace, while still demanding, was generally less frenetic than what I was used to. Culturally, I had to adapt to a new healthcare system, different communication styles, and a new social environment. Initially, I experienced a period of adjustment and culture shock. While I welcomed the improved resources and more structured environment in the UK, I initially missed the fast-paced dynamism and the strong sense of camaraderie I had developed with my team in India. I also had to actively learn and adapt to new UK-specific protocols, medication administration practices, electronic health record systems, and communication norms within the UK healthcare setting, which required a period of focused learning and adaptation. To cope with this significant change and ensure a successful transition, I employed several key strategies. Firstly, I embraced a proactive and positive mindset, viewing the change as an opportunity for professional growth and expanding my nursing skills in a new healthcare context. I approached the transition with openness and a willingness to learn and adapt. Secondly, I actively sought out mentorship and support from senior nurses and colleagues in my new UK workplace. I proactively built relationships with my team, asking questions, seeking advice and guidance, actively participating in ward-based training and orientation programs, and readily accepting constructive feedback from my UK colleagues. This proactive approach to seeking support was invaluable in navigating the initial learning curve and feeling integrated into the new team. Thirdly, I focused on active listening and observation in my new environment. I paid close attention to how senior colleagues practiced, how communication flowed within the UK team, and absorbed the nuances of the UK healthcare system by being a keen observer and listener in my first few months. This helped me quickly understand and adapt to the subtle differences in practice and communication styles. Furthermore, I made a conscious effort to connect with colleagues both professionally and personally, building relationships and fostering a sense of belonging within the new team. Participating in team social activities, showing genuine interest in getting to know my colleagues, and actively contributing to a positive team environment all helped me feel more settled and supported in my new workplace. Finally, I maintained a commitment to reflection and continuous learning throughout the transition. I regularly reflected on my experiences, identifying areas where I was adapting well and areas where I still needed to develop my skills or understanding of the UK system. This reflective approach allowed me to proactively target my learning and continuously improve my performance and integration into the new environment. In summary, coping with this significant change required a combination of proactive adaptation, seeking support and mentorship, keen observation and learning, building strong team relationships, and a commitment to continuous reflection and professional growth. While initially challenging, this transition ultimately proved to be an incredibly enriching experience, broadening my professional perspective and enhancing my adaptability and resilience as a surgical nurse in an international context.